Okay, now we are starting. A very good evening, everyone. I am Dr. M. Shia Jaiswal, currently pursuing PhD in oral and maxillofacial surgery from Busan National University, South Korea, and I am the host for today's session. Today we have Dr. Rohan P. Raut from India with us. He has completed his BDS from Vasant Dada Patil Dental College and MDS in oral and maxillofacial surgery from Vokaligara Sangha Dental College, India. He has also done fellowship in craniomaxillofacial surgery from Majumdar Shaw Medical Center. Moreover, he also did masters in cortical implantology from IACI, Italy, and Nobel Biocare Jagomatic implant course from Chennai. Later, he started his own practice named Pravara Specialty Clinic in Kolhapur. Currently, he is working as a visiting maxillofacial consultant in various hospitals in Kolhapur and have been associated with Quickdent for about 8 years.
Thank you, Dr. Shreya, for the introduction. I'll just share my screen. So basically, today's topic will be bicortical implants, mediated prosthetic rehabilitation in resected, reconstructed, and compromised jaw condition. Dr. Shreya has already introduced me. I am Dr. Rohan Raut. I am practicing in my hometown, Kolhapur, Maharashtra. I have done masters in oral maxillofacial surgery. And moving towards our seminar, first of all, thanks to my mentor, Dr. Paul C. Salins, under whom I have done my fellowship. Behind him are all his famous paintings. He's a great painter. He's a great artist. He's a great surgeon, well renowned, like worldwide. And he's the one who has told me we were doing fellowship in 2015, and he said we got a flyer stating that immediate teeth or fixed teeth in 72 hours. So he was like surprised, like how is it possible? Because we generally knew the conventional techniques like bone graft, wait for 4, 5 months or 6 months, then go ahead and do the loading or the prosthetic rehabilitation. So he was curious. We all were curious. So I went to attend a few seminars on the bicortical implants. That is a time in 2015. I went to Chennai and met Dr. Mayur Khainar. He's been associated with Quickdent now, and we started he started sharing his cases. I also got interested, and I found like it's a viable option and it can be done in various cases too. Like why to wait for so long if the patient is benefited, if he can chew and start eating after 72 hours, it's really beneficial. So this was the center where I was been working, Mazumdar Shah Medical Center, and this is the center currently I'm working. This is in my hometown, Kolhapur. So today's aim, it's not like any fancy things. I will not be talking about the resections, how I did, or the reconstruction methods, because these are all theoretical parts, and it cannot be just taught or been explained in a 45 or 1 hour webinar. So just today's, it will be an upgrade for your implant clinical practice to search or to learn different alternative options other than the conventional implant, which has been routinely practiced, and to increase the most important to increase the implant conversion rate in the clinical practice, because now the patients are become more aggressive. They want treatment options which can be easily done without much of waiting, and with less cost effective, like more cost effective also. So definitely, as a dentist and as an implantologist, we all should upgrade ourselves, and we also should search for different implant options, which would be beneficial in our clinical practice, which will increase our revenue also. This is the most important thing, and it will be beneficial for the patients too. So this abstract you have all, like Dr. Shreya has already explained about it. So when I was doing I was doing my graduation in 2005. Most of our senior lecturers or our batchmates, colleagues, they used to say like the bread and butter for the dentistry is endodontists and the prosthodontists. Like these are the routine cases what you will generally get in your clinical practice, and you should focus more on that. But nowadays, I would say like those things are there, like bread and butter. But now another cream part has been added to that is the implants. Patients now the question about more about whether you are doing implants or not, because the patients are not maintaining their oral hygiene because of the fast food. Patients lose their teeth because of the more aggressive parodontal conditions. Routinely, we don't get like a normal conventional implant cases. So we should be upgraded. We should be ready to deal all these cases in our clinical scenarios. So I would say like implantology is now becoming the biggest like cream part of the dentistry. Like everybody wants to learn more into it, and every individual, like every graduate who has been passed out, they want to place an implants. But I would just recommend that them like to have a general knowledge like about all the procedures, when to do, where to do, and when not to do, which procedures, which like clinical scenarios you should like previously be prepared to give justice to the patients. So basically, in today's webinar, I'll be speaking about few cases which I have done. Uh, this is the case one. This is really close to my heart because this was the one of the few first cases which I have done when I started my bicortical implant journey. The patient came to us with a complaint of swelling in the mandibular region. As you can see in the premolar molar region, there's a huge mandibular swelling, and you can see some missing teeth. So previously, this guy, he has already undergone multiple surgeries. Two conservative surgeries were done. Curettage was done because there was a previous lesion in these areas, but they were managed conservatively. So, but again, there was a recurrence, and it was been seen in the premolar molar region. So I had taken the medical history, dental history, everything. There was no habits. Preoperative clinical examinations was done. Biopsy, bone biopsy was done incisional, and it came out as an amyloblastoma. So this is a pre-op OPG, and so I don't have this CT scan because this case was done in 2016, 17 times. So this is a OPG, which has been pre-op OPG, which is present. So the treatment plan was done, the phase one part, which requires like segmental resection and reconstruction. Because this is a young patient, so you cannot just put plates, recon plates, and leave it because he needs a fixed option. Prosthetic part later on needs to be managed because this guy was like 23 years old, just passed out, just has completed his engineering, and he was working in a good company in Delhi. So we had done a segmental resection, and reconstruction was done with a non-vascularized iliac bone graft. So as you can see here, the resection was done intentionally intraoral. Extraoral resection was not done because to avoid the scar which forms, very bad scar which forms because of the submandibular incision. And as it is a benign odontogenic tumor, amyloblastoma, it does not require any submandibular nodes resection or dissection. So only the intraoral resection was done. This is a resected specimen. As you can see here, the lesion and a safety margin has been kept. This is a normal bone area in the anterior and the posterior, so that the chances of recurrence would be minimal. The iliac bone graft that was being harvested, a 5 centimeter long bone graft was taken. As you know, iliac bone graft is a unicortical. It has a thin cortical plate. There is a thick cortex here, that is the iliac crest part. And this is a thin cortical bone. So it's not a bicortical bone graft. It's really thin. So what I have done is like the lower border, the thick iliac crest part was kept in the lower border intentionally to avoid the fractures. And the upper part, the thin cortical, unicortical part, was placed fixed with the mini plates and screws. And over that, all the cancellous bone which was been harvested from the iliac bone region was just sandwiched between, and then the closure was done. This is the immediate post-op X-ray OPG, which shows this is the bone graft area. This is the plates. The 10 months post-op, as you can see, there's a good union of the grafted bone and the natural bone margin. There's no fractures or there's no like a radiolucency seen. Bone plates are intact. So post 10 months, what we did was first thing was we removed the plates. That was done intraorally, like yeah, on the dental chair only. The bone plates were removed. Only the upper parts, lower part were not removed because it was too deep and it was not possible locally. So phase two, there was again patient came with a complaint, and this time it was not recurrence, but it was like he was unable to chew food. There was like a depression on his face. The lip part was like it has been because of the hollowness. There was no teeth, so there was a depression in the cheek and the lip region. So this is 1 year post-op. Remember, 10 months we removed the plate, and again post 1 year, like again after 3 months, we took an OPG. The healing was there, and the lower plate was maintained. It was not removed. Again, clinical radiology examination was done. There was no signs of recurrence. Healing was good. Bone remodeling was seen. There was a paresthesia in the lower lip. Post-op CBCT was done, which showed good union. Crestal bone was also good. Lower border was thick. You can see it on the cross sections. But the anterior, like the crestal part, there was a triangular bone. It was not thick because remember we had kept unicortical. It's a unicortical bone graft. The crestal part was kept on the lower border, so the width was good in the lower part, but not in the upper part. So placing again a conventional implant would be a bit challenging, and again doing a bone grafting, the patient would have to wait again for another 6 months or 9 months. So the patient didn't want to wait, and he wanted a good like immediate option. So what treatment options like RPD? Definitely he refused. So went for an immediate implant supported prosthesis. Again, there were many problems. Non-vascular bone graft, unicortical. Bone width was not as like sufficient because if you take a fibula bone graft, it's a bicortical, and if you take a double barrel bone graft in a fibula, you won't face these problems. But in the iliac, definitely it's a unicortical, so these problems are there, but it has been managed. So later you can see the graft was placed buccally, and I did this case in general anesthesia because the lower plate has to be removed because it was in the site for the bicortical implants. So I have to remove that bone plate first and then implant drilling like implants were placed. The treatment plan of bicortical implants. So when I came back from the various seminars, I just told my boss like this is the rationale. Bicortical implants is also scientifically proven. It's not like a magic or it's not something it is came out of box. There is a definitive science behind it. The scientific reason is like the orthopedicians, they use this bicortical implant technique, like bicortical engagement, unparallelism, and splinting. That is what has been done by the orthopedic to treat the long bone fractures. Whenever long bone fractures are there, this treatment is done, and immediately the orthopedician or the surgeon tells you to like move your limbs, walk, lift, like not too heavy, but raise your arms or something. Those kinds of instructions are given. Similarly, in the bicortical implants in the dental conditions, bicortical engagements are done, unparallelism or parallelism, anything, and splinting. Splinting is through the rigid fixation by the prosthetic. Any prosthesis, and underneath there should be a metal frame and the prosthesis part. And maybe it could be ceramic or zirconia or a hybrid, anything, but it should be rigid fixation. That is the most important principle for the bicortical implantology and the success reason also. Because if many people do a PMMA without a metal frame, and it definitely fails because there is no rigid fixation. These were the in the grafted area, the bicortical implants placed, unparalleled transfer coping impression procedures, lab workup. I just go through these because routinely, if you are doing implantology or anything, these are the basic steps that we do. Zig placement to create the parallelism for the prosthetic work. Zig trial in the patient. The zirconia prosthesis was been given. And this is the post-op OPG after implants. So you can see the 6 bicortical implants have been placed. Two of them, this first one and the last one, the red circles which are marked. These are basically in the natural bone area. Because before doing this case, I searched a lot in the literature whether I can get few cases where bicortical implants have been done in iliac bone, but I found none. No cases, no documentations was there. So what I tried is like placing these two implants at least in the natural bone so that there would be a good anchorage. Definitely these were also good anchorage, but there will be a doubt always like how it will react. It's a grafted bone. It's not a inside like on the same mandibular bone. It's a secondary like transferred bone. So for that reason, I placed these two implants in the natural bone area. So this has taken up nicely. This was the post cementation, the occlusion, and the extraoral appearance. So now, even after looking at him, like nobody will say like he had undergone a resection. There's no scars, absolutely no scars. Lip, facial appearance, or everything is like looking like a normal person. These all things need to be planned properly. What are the aesthetic demands from the patient? What you should be giving? What should be the output? What should be the end result? Case two, which is another resection case. In 2021, as you all know, we were been horrified by the COVID pandemic. And during that cases, most of like my clinic was also been shut down. Nobody was been working, but still I was been going to the hospitals because during that pandemic period, we had many cases of black fungus or mucormycosis. So during that time, I was teamed up with the in Kolhapur, in my hometown, with many ENTs to treat the mucormycosis because it was basically affecting a lot of jaw, maxillary regions, and because the reason for the maxillary bone involvement was the sinus area and the nasal because the mucormycosis first affects the nasal area, nasal part, nasal septum, nasal sinuses, and because of that, if over that, or if your immunity was less, and you had many secondary, the patient had many secondary like diabetic or hypertension, then it used to spread into the maxillary sinuses and the maxillary bone area. So one of the patient, like he came to clinic and there was a pain in the upper jaw and mobility. After investigations, he was like he had a COVID history and a diagnosis of post-COVID mucormycosis was done. He was admitted and posted for surgery along with the ENT. Total maxillectomy part was been done by me and endoscopic fest was been done by the ENT people. So this is the resected specimen. You can see this black areas. These are the mucormycosis, which is affected the maxilla. The maxillary bone will be completely porous. It won't bleed much. And these are the already the teeth were avulsed from the region because of the bone loss. Your gums, your soft tissues will be affected. There were multiple pustules in the from the gums area. So the resection part was been done. histopath reported as confirmed the diagnosis of mucormycosis. And this is post surgery. This is actually 1 month post surgery. Wherever possible, like all the cases which I have treated for mucormycosis, I tried to preserve the palatal mucosa as like wherever it was possible. If there was like perforations or if there were like pustule pus formations or dehiscence pre-operatively in the palatal mucosa, then definitely I have resected that. But in few cases where the palatal mucosa was good, I have tried to preserve it because that reduces the chances of regurgitation. Because if the palatal support is not there, palatal flap support is not there, a lot of like patient's speech will be affected, lot, and the patient will have difficulty in drinking water also. So I try to preserve the palatal mucosa. Unfortunately, there will be dehiscence because on the both the sides dehiscence was there, because definitely you cannot stretch the full gums or the cheek part and suture it. So this part was left like that, and then immediately patient was rehab with the bulb obturator denture. I waited for this. I didn't jump for a fixed prosthesis immediately because during those times we didn't know how it will react, whether there will be recurrence or not. I didn't want to put every heavy like all those patients' money into the implants, and then later if failure will be there, it will be a burden for him. So I just first I placed a bulb obturator denture that corrected his speech and it helped him a lot for his chewing. So aesthetically, patient was really satisfied because he was a young patient and he had to go to job. He was 35 years old, and he said to me like he cannot go to work because he had that social stigma. He lost all his teeth. Whenever he used to speak, other people won't understand what he was speaking. Um, So definitely he was happy. His speech was corrected, his aesthetic part was corrected, but not functionally. He was not able to chew properly. The mobility of the denture was there, and repeated relining also demanded a fixed option. So the prosthodontist was also not happy with this. So he also requested like we need to deal with this because he has to visit frequently to my clinic to correct the denture part. So in 2022, 1 year post-op, CBCT was done. So as you can see here, only the zygoma part is remaining, but that zygoma part is also not that thick. It's the like perforation, like this cortical bone formation is really thin part which has been remaining. So I didn't want to fracture this because this is the only last option the patient has. You can see here, the orbit, there's no orbital floor. Nasal part, only a thin part is remaining. The zygoma part, it is present, but it's not that thick cortical bone. The maxilla is totally missing. So I waited. I just put the temporary and I put the implant plan on hold because the bone density was not that sufficient to hold the zygoma implants too. So it's better to like wait and plan at a later stage when you have like a confirmatory region, like bone density should be good. You just like zygoma is the last option. If you fracture that part also, then patient is left with no other option. And reconstruction of the maxilla, whole reconstruction with the fibula or any other bone graft is really difficult, and it's not that possible. Like it's not that 100% guaranteed part. So I waited for another 2 years, and in 2024, miracle, there was a good bone formation. So this was the benefit of waiting for 2 years. Definitely, patient was like he has to manage with that bulb obturator. We try to reline and try to satisfy him and try to convince him. And he was a bit like young guy, educated guy, so he understood what the problems were. And not going for an immediate rehabilitation, he thought that it was a good option. He had many consultations, like he went to other clinics and all, but still he came back and we did this. I did this case. There was a thick cortical bone formation, zygomatic bone areas. So compare it like 2022 and 2024, the huge difference. Now definitely we can go ahead and do a quad zygoma or zygomatic implants. So that was the treatment plan. I did a quad zygoma, two on each sides. The zygomatic implants were placed. The day one. And immediately I requested the patient that we will be doing a post-implant CBCT because this was a really challenging case. Doing a zygoma implant in the mucor cases or in any resected cases is the main challenge is all these are the scar tissue. There is no maxilla. You literally have to dig from here and reach the zygoma part. And it's really tedious. Your hands will pain while retracting. It is that stiff, and there's no anatomical landmark remaining there. Everything is empty. So I didn't want to take any chance before going ahead with the prosthetic part. So I did a post-op CBCT, and this was like the engagement was good, bicortical engagement, both the sides, in the cord zygoma region, and everybody will be surprised with this treatment plan. Immediately, implant-supported overdenture was given. Now, everyone will ask, why overdenture? Why not a fixed prosthesis? Even after giving a quad zygoma, even after such a good engagement on the post CBCT scan, so why it was like given a denture option? So basically, there were two reasons. Previously, the patient had dehiscence in the cheek region, in the vestibular region. After the implants, that dehiscence increased. That was meant like that was expected. Like when you are going through that same region, that dehiscence increased. He again developed the nasal speech, air escaping through the mouth, nasal regurgitation, oral antral communication was there. So to cure that, I have just temporarily given a overdenture. I will be going on with the fixed prosthesis. I'm waiting. And again, because to close that the gaps, dehiscence part should be closed. It should be minimal to give a fixed prosthesis. Second reason was that the bar which you are seeing or the implants positions are way far behind than your lip because there is no maxillary bone. These are the points. These are the regions where the implants are there, and this is the point where your labial teeth are there. So this is all the cantilever part. So I don't want to risk my implants, even though there's a good engagement. I still don't want to risk because that is the only option he has. So I went in for a removable option temporarily. Then later it will be given. Then he will be. I'm going to give a fixed option. So this is the pre and post. You can see here the nose is drooping. The lips are far way behind. So too much of cantilever forces are not good for any implants. This is the third case. Implants in the post-cystic cavity. It's not that big cyst, but it's these are the cases where routinely you all people can find in your clinical practices. So that's why I'm showcasing this case. Patient came with a swelling. You can see a large cystic region in the anterior region, 2-2 and 2-3 region. Labial plate is almost gone. Palatal plate is very thin, and this is a huge cystic lesion. You can see here radiolucency. So it's a huge, large periapical radicular cyst which has been present. So the treatment plan again, immediate extraction of the cystic enucleation and bicortical implant placement. So post extraction, you can see this. There is no labial plate. severe bone loss is there, but still we can do implants and immediate rehabilitation can be done. So bicortical implants were placed. The first one is the complete polished surface, and the second one is the cortical SP, is the picture is shown here, where the tip is polished. The second part is a rough surface, like your conventional implant. The threads are more aggressive. It condenses the bone, and the apical part again is polished to prevent the peri-implantitis. So after this, everybody will imagine like most of the dentists or wherever I go for consultation, they say, do these polished surface implants really integrate? Because it's a polished surface. Do they integrate? That is the first question they ask. Because we were been taught, like brain mark used to say, like rough surface, all the treated rough surface. Those are the things where osseointegration happens. But the polished surfaces also integrate, because when we do a trauma case, the implants what we place are titanium and those are also polished. And in few cases, in later, like after 4 or 5 years, when you try to remove those plates, the bone will overgrow over that plates, and it's really difficult to remove that plates also, even though it's a polished surface. So in this scenario also, I did bone grafting like conventional implants, and membrane was placed and sutured it. And this is 2 years post-op. So you can see here bone nicely it has been formed in that defect area. The crestal level has been maintained. So definitely we can say it has been integrated. Otherwise there will be a huge radiolucency if it is not been integrated. And this is 2 years post-op. This is again 2 years. You can see nice gums, healthy gums, no recession. So these are the small cases also which we can like resection, reconstruction cases. Not we don't get those kind of cases daily. These are the small cases which will be getting it in our clinical practices, and this is the cases like where we can manage with the bicortical implants, and immediate loading can be done. This is another case, trauma case, young guy. He had a fracture here in the parasymphysis region. He had a trauma, plating was done, it was removed. These are the bone graft because there was a defect there, but still could not manage to get the crestal bone. The thin plate was remaining. So again, bicortical implants were placed and the prosthesis was given. So what will be the learning points? Like as the world-renowned investor has said, like don't put all the eggs in one basket. So you need to have different baskets in your clinical practice. So this is my basket. Different multiple options of implants you need to have in your clinical practice, because one single implant cannot be used in all the clinical situations. You need to have various options. So these are the cortical zygoma implants, the two-piece implants, and these are the cortical zygoma single-piece implant. These are the polished, these are the rough surface. The tip is the rough surface and the engaging part, and the rest is the polished part. These are the Quickdent implants, OC type. These are really aggressive. These can be easily used in D2, D3 bone and immediately loaded. The apical portion is very active. It goes and crushing the bone and it can engage into the cortical area. The middle part is double threaded, which will condense the bone. You condense your compressive part, compressive bone, cancellous bone, and the apical part or the crestal part is tapered to prevent the peri-implant chances. These are the cortical TPR implants, where again the tip is polished, middle parts are compressive, like your conventional implants, and the crestal part is again polished to prevent the peri-implant chances. These two are the single piece, which I have shown in that cystic case. This is a cortical SP and the cortical basal. This is polished, completely polished, and this has a rough surface. So these are the armamentarium which you require. And a single system is really good because you don't have to maintain the inventory. A lot of kits will be present in your practices to maintain that. So it's a single system is sufficient where they have all the options. They have a screw retain option, internal hex is present, multi-unit options are like they have like from straight 17-degree, 30-degree, 45-degree. In Zygoma, you have 52 and 60-degree also. We have like digital scanning library, scan bodies are present, and implant bodies, so which help in the digital scanning process. These are the images to showcase about these scanned bodies and the in the digital planning. So these are the few cases wherein the cortical SPs have been used. D2, D3 bone, immediate loading has been done. Is a cortical TPR case. Two-piece implants, screw retained option, because generally wherever bone width is good, periodontal is not compromised, patient is like educated, or if he can maintain good hygiene and all. I generally prefer two-piece implants because it's a screw retained. If any future problems are there, we can just retrieve it. Single piece, it's a cement retained, so any problems are there, it's a bit difficult. But in few scenarios, you have to go in for a single piece implants wherever there is a aggressive periodontitis, thin bone is present. Similar case, this case I have treated with the cortical basal implant, and zygoma implants were also placed because it was a severely periodontally compromised. He had gingival swellings, calculus was present, immediate extraction was done, and implant placement. And within like a period of 10 days, rehabilitation was done. I call these like yoga implants. Superior bending qualities are present because whenever you do a bypass, you need to bend it, because otherwise if it is too buccally present, you will land up in a crossbite. So bending property is really important. This is another case. I'll just share you a video. This is a lady who was wearing a denture, mostly for the aesthetic part. Completely, there was no bone. Tongue was too bulky because extractions, I think she had lost her teeth long back, and tongue was like huge tongue was there. So this is a pre-op OPG. As you can see, there's completely no bone. So the treatment plan of all on six protocol, full mouth rehabilitation with the two-piece implants. Definitely it need zygoma implants. So this was the day one, zygoma implants, bilateral pterygoids, and this is a post-op CBCT immediate. So you can see a good engagement, right and left zygoma, right pterygoid region. It's engaging into pterygoid fossa, left pterygoid implant, again impinging into the pterygoid fossa. Lower mandibular region, there is a bypass has been done, keeping a safe distance from the canal. It is engaging into the lingual cortical bone. 3-6 region, and in the anterior mandibular region. Again, it has been perforated the lingual cortex. So basically, the cortical engagement is must for an immediate loading, whether it may be a single piece or a two-piece implants. This is in the 3-3 and 3-4 region. This is in the maxillary anterior region. So now we can see the width in the maxillary anterior was less, but still two-piece implants have been placed. because the cortical TPR implants, they have this condensation. They will just expand the bone and they will go in. The tip is engaging into the nasal floor. Again, the principle of the bicortical engagement. This is in the 2-3 region, maxillary left region. Is the post-op. Prosthesis has been given. Occlusion, smile, screw retained prosthesis. It's really a relief when you give a screw retained prosthesis because anytime anything happens, you can just retrieve it. This is the last case. It's not been completed yet. I'm still doing this case. It's a really one of the special cases. It's a case of an ectodermal dysplasia. So this is a young boy, 20 years old, and as you can see, the classical signs: sparse hair, ectodermal dysplasia. There was absolutely excess sweating was there. So he has this pores on his nasal region, missing teeth, complete anodontia in the mandibular region, partial in the upper region. Only the canine and the molars are present. This is a pre-op OPG. So planning has been done and zygoma definitely, but not a cord zygoma because as you can see his facial features, his cheekbone is really thin. The width is not sufficient for a cord zygoma. Definitely, if you try to place two zygoma implants, the distance between the two implants, like the conventional, what we just say, like 2 to 3 millimeters of bone should be there between the two implants, it won't be possible, and it's really thin. If you try to place two cord zygoma, this might fracture. So I went in for a single zygoma, like right side one and left side one. This is the anterior bone region. It's extremely thin bone. This is a post-op OPG. So two zygomas, right and left, two pterygoids. Again, a good bone to engage into. And anteriorly, wherever I find like good bone, I try to place one implant, cortical TPR and OSSI implant. Mandibular, I am just waiting for the upper implants to heal because it's a really thin bone. So I am just doing a delayed loading in this case. Later on, lower, I am planning for a single piece implants because there is absolutely no width. So two piece will be really difficult. So planning for a single piece implant and simultaneously I'll be loading both upper and lower together. Thank you everyone for patience listening and thank you Dentist Channel Online and Quickdent for giving me this opportunity to speak. And I thank all the participants who attended this webinar. As today is Sunday, a family time, but still you all are here. Really thank and appreciate that. You guys all can follow me for more updates on my Instagram account or Facebook, or you can mail me if you have any cases in Kolhapur, in my clinical practice, I do one-on-one like teaching. I don't go outside and do like seminars or do these 3 days courses and all. I do more routinely one-on-one cases. Any cases are there in my hometown. The dentist, which they cannot manage, they come to my clinic. I invite them. I tell them, you are welcome. You can witness, you can assess, you can see these implant placements, how zygoma implants are done, pterygoid implants are done. What are the protocols? How the prosthesis? What are the challenges? Because seeing only just pre and post is really fascinating, but the pain behind that is really more. So definitely, thank you a lot. And any questions are there, I'll be happy to answer them. Over to you, Shreya, Dr. Shreya.
Thank you so much, Dr. Rohan. And now it's Q&A time. So yes, let's see. There are a few questions. So the first question is, Doctor, that sir, how Do we do implant placement if mouth opening is less and patient is wanting a fixed prosthesis through implants?
So basically, if like the doctor is asking this question means there is some problem. It could be a submucous fibrosis or it could be a post carcinoma wherever grafting has been done or PMMA bone flap has been placed. Definitely in those cases, mouth opening is restricted because of the trismus, fibrosis of the graft area. So basically, zygoma or any other implant cases, you definitely need mouth opening. If that is not there, you need to first correct that. If it is a submucous fibrosis, you can go ahead and correct it. If it is like a stage 1 or 2, you can correct it with the injection part. If it is stage 3 and 4 submucous fibrosis, then definitely it needs a surgery, nasolabial flap most preferably, and then go ahead with the implants because in reduced or restricted mouth opening, angulations or the oral hygiene maintenance, it's really difficult. And in post CA cases, whenever there is a radiotherapy or chemotherapy, patients will have xerostomia, so there are chances, a lot of chances like peri-implantitis or failure will be there. So I would recommend first to correct those things and then go ahead and place an implant.
Okay. So the next question is from Rahul Ahirao. How to do buccal and lingual bypass?
Buccal and lingual bypass, definitely it is really challenging, but it's all tactile. You have to first, I cannot explain it, but if it's a live seminar, I could have shown it on a mandible or I could have demoed it. I have a mandible. So this is the, I hope it's visible.
No, it's not visible, doctor. Yeah, now it's visible.
Yeah,
Just
this
keep,
is,
yeah, just keep in front of you. Yeah.
yeah, so this is your buccal region and this is your lingual part. So you will have a good mylohyoid ridge. That is the most important landmark for buccal lingual bypass. And definitely you need a pre-op CBCT scan to just check how, like where the infraalveolar canal is there. So whenever you're doing a buccal to lingual bypass, you have to first and identify the landmark, mylohyoid ridge, and then you have to judge like from buccal region to the mylohyoid region. So you have to keep one finger in the mylohyoid ridge area and drill in the other hand. And basically you have to join those two dots. So you have to connect, you need to feel the perforation. That is the most important thing because half-heartedly you cannot do. If you do half-heartedly and if you try to bend, you will fracture the lingual plate or the buccal plate. So you need to engage the cortical area and then you have to bend it. So I tried to explain it, but I think practical part in a live seminar, it would be a live practical session. It will be more clear to explain this case, this question.
Yeah. Okay, the next question is from Sheikh Shadab. Was the patient satisfied with overdenture in case 2?
He was satisfied because there were 5 ball attachments which I had given in the overdenture over the bar, and we have loaded only 3, as you can see in the PPT, because we don't want to put more pressure because overdenture he has to remove it daily. So removing and placing, it should not again create more friction or forces over the bar on the implant. So I have loaded only 3. I think 3 are more than sufficient for any like for chewing hard substances. Definitely he's eating properly. I just explained him the scenario and just you have to tell the patient. Patients are ready to wait. If you tell them the scenario why we are doing this, then definitely he waits. The patients are going to wait, and he's happy. He is eating nicely. He's going to his work. He doesn't have that fear like the denture will fall. Previously, because of the obturator, he had that fear like it is falling down, falling down. So he used to again push the denture with the mandibular teeth. So that fear has gone. He has gained the confidence. So definitely he is happy.
Okay. The next question is that what are the benefits of polished and rough implants?
Benefits, like it depends upon the case scenario. As I said, polish and rough both are good because both osseointegration is been seen, and you have to judge clinically what you want, like you whether you want a cement retained prosthesis, screw retained prosthesis, whether the bone quality is good, bone height, width is sufficient for a two-piece implants, then definitely go for the two-piece or a rough surface implants. If during like preoperatively there has been severe periodontal compromise case is there, then don't go ahead with the screw retain or a polish or a rough surface implants, because there is a high risk that the patient will again develop peri-implantitis and there are high chances of failure. So it depends upon the case scenario. Definitely both are good. You need to plan it and you have to choose.
Yeah. The next question is, sir, you have not explained buccal bypass.
Okay. Buccal bypass. So definitely it's the opposite thing. Whatever we do it in the lingual bypass, same thing you have to do it the buccal bypass. So you have to approach from the lingual area and go towards the buccal area. So the perforation part, there is no landmark, like the external oblique ridge is there in the posterior region, but you have to go a little bit more behind. If you try to engage in the lower part, the lower border of the region, that is the point where you have to engage in the buccal bypass. But when to do a buccal bypass and when to do a lingual bypass, that is a good question. How to do is a different question. Whenever you see a CBCT scan, the canal is located more buccally, like buccally, or if it is in the inferior region, then the lingual bypass is really good option. But in some cases, like I have encountered where the inferior alveolar canal is more on the lingual side, on the mylohyoid ridge region, and it's really difficult to do a lingual bypass, because if you try to do a lingual bypass and try to save the inferior alveolar nerve, there's a really thin bone remaining, and it won't be sufficient to hold that implant. So in that cases, you have to do a buccal bypass.
Okay.
So it
So
depends
this
upon
was,
the inferior alveolar nerve location.
I hope you guys have received the answer, and Dr. Rohan have already cleared the doubts. So this was the last question. So thank you everyone for joining with us, and whatever cases Dr. Rohan have shown, like you can learn from it. In this webinar you learned about the bicortical implants and other implants also, and regarding that he also told few cases that he has done, whether like in the resected jaws or reconstructed jaws. So through this advancement in implant designs and surgical techniques, the prosthetic rehabilitation, I think in these challenging cases, the cases that you have shown, it will be more predictable and more effective. So
Yes.
I think, yeah, you need to incorporate these things and learn more and more about new innovations and new techniques. So, yes, this was all about today's webinar. Thank you everyone for joining with us. And thank you, Dr. Rohan, once again for such a informative and such insightful session.
Thank you very much.
Thank
Thanks,
you,
Neha.
everyone.